Okay, welcome back, everybody. We're about to start the second session of part two, and I'm very pleased to introduce Dr. Glyn Stacey. I'm sure many of you are familiar with a lot of Glyn's work, including his former chair as the Society for Low Temperature Biology Chair. Until recently, he worked at the National Institute for Biological Standards and Control in the UK, where he did many great things, including setting up the UK Stem Cell Bank. Now he works as a consultant with SSCBIO and also for the International, is it the Stem Cell Bank, Glyn, in Beijing?
Okay, thanks very much.
Thank you, Glyn. Take it away.
Thanks for the introduction, John. So welcome everybody. Thanks to, I've seen there's quite a wide range of people participating in the meeting today from all over the world. So that's very impressive. I just wanted to say that I'll be trying to keep us to time fairly tight. Yeah, we've all been on Zoom now for quite a bit, and to avoid Zoomitis, I think it would be great if we could make sure we all the speakers try to keep their time. So I'll give you a little reminder if you're getting close to time. So please don't be upset by that. It's just to help keep us going on time. Okay, so with that introduction, I think we've got a great set of speakers for this last session on some of the practical applications, and this will be starting with Peter Kilbride from Cytiva, I think it is, if I pronounced that rightly. Previously, or still, maybe Asymptote. Maybe Peter, you'd like to explain your affiliations and talk about quality control aspects for cryopreservation and development.
Perfect. Thanks very much for the introduction. I'll just share my screen now. Perfect. Yeah, so thank you. So yeah, so my talk today, the title is Quality Control and Practical Approaches in Cryopreservation from the Bench-side to the Bedside. And I'm based in Asymptote, which has been around for many years. I've worked there for about 6 years now. It's now part of Cytiva, was formerly part of General Electric Healthcare. And day to day, one of the big parts that my role involves is converting. We have a lot of collaborators we work with in more research environments, and then we want to try and convert those research environments and projects and processes into something that can be a cell therapy. And that's sort of the basis of what I'm going to discuss with you today. So to give you an outline of my presentation, I'm going to start with a fairly high-level overview from the lab to the patient. So what's the difference between working in a research environment and what's the difference when it goes into some sort of cell therapy? Of course, from a cryobiological point of view, they're very similar, but in terms of practicalities and in terms of regulatory issues, they're often quite different from each other, and these need to be taken into account. One of those in particular is looking at quality control segments and treatments. That's something that's very common, and there's a few sort of problems and solutions with those, so I'll go into that part in more detail before finishing up with, again, a fairly high-level view of some of the practical challenges from scaling up from a research environment to some sort of clinical treatment, and things you can do early on if you're in a research environment to make it easier when you want to finally move to actually putting something into a patient. So what are the key differences between a research environment and going into the patient? So I've put here just a typical step process of what typically you'll find in your lab, in your clinical research, not your clinical, sorry, your research environment preservation process. Of course, there's many different processes. It's just a typical example. But often you start with your cryoprotectant, you'll make it in the lab. It's normally composed of DMSO, depending exactly what you're doing, but it can also include other cryoprotectants, glycerol, HES, hydroxyethyl starch, sugars, and calf serum. In fact, often the cryoprotectant is just made up with DMSO and culture medium, so all the different chemicals you have in your culture medium will be there. You'll then prepare the cryoprotectants and the cells, put them into normally 1 or 2 ml standard cryo vials, and then cool them either in a control rate freezer or a passive cooler, say such as a Mr. Frosty, and put it directly into a -80 freezer before storing it, thawing it, and then either using it or assessing the process overall. However, when it comes to a typical, say, a treatment process or something that will be a cell therapy, where the cryobiology of your cells is still going to be the same, practically it tends to be a lot more complicated process. So again, here's a typical process, varies treatment to treatment, but typically you'll start with your initial biological sample that's normally taken from a patient, either from the patient taking the treatment, autologous one, or something allogenic, something that will be taken from one person but ultimately used in a different person or many different people. So often you'll get that sample, you often cryopreserve it immediately and then ship it to whatever your manufacturing site is. That manufacturing site can be in the same hospital, or it can be hundreds of miles away from the patient. You'll then thaw that sample when you're ready to start the manufacturing process, and then you'll go through the steps of converting whatever your initial sample is into whatever your final cell therapy is going to be, the general culture phase. Then at the other step, you have to do cryopreservation again. So you often then cryopreserve that treatment. You then store it for long term and then ship it and thaw it, and then usually thaw it by the bedside and then use it immediately for the clinical application. So it's a bit of a more complicated process. And in this example, I have 2 different cryopreservation cycles as part of the same cell therapy, but often you'll have more or less depending exactly what your final cell therapy is. But this is a typical overview. So what are some of the main key differences that you'll really find when you're actually going to this sort of final cell therapy step? So the first thing, and I think most of you are probably aware of it, but the cooling must be very tightly controlled, reproducible and traceable. So what that actually means is usually by this step you've got to use a control rate freezer. Usually passive cooling can no longer be used in something that's going into a patient, because you have to be able to prove you're doing the exact same thing every time. For example, a passive freezer, if you put it in a -8 and someone opens the door, then that'll disrupt your cooling profile. Or if it's at the top of the freezer or the bottom of the freezer, that will change slightly your cooling profile, which could affect the product and deviate from the approved protocol. But normally with control rate freezers, you can prove doing the same thing every time. And I think pretty much all control rate freezers give you some sort of printout at the end. So if there was some sort of problem with the treatment after being given to the patient, you can look back and say, well, here's the graph of the cooling process. We can show that it was done properly as per the protocol that we have proven worked. So we know the problem wasn't there for other investigations. The next step's often overlooked, but as a key point, that the vials or the cryo containers used need to be hermetically sealed and need to be tamper evident. So for example, screw top cryo vials cannot be used in cell therapies in general. And the reason being they're not hermetically sealed, so they can potentially leak and then contaminate other samples that are stored in the same place, or they can have liquid nitrogen ingress into them, which can be dangerous when you're opening the vial, but it can also be dangerous in terms of liquid nitrogen itself isn't sterile, so you can introduce contaminants to your sample. Typically, people use, there's vials available that are hermetically sealed, and they go from maybe 1 or 2 mils up to about 50 mils. And also cryo bags are very common as well. Typically just a larger volume, say 15 mils minimum, and they can go up to hundreds of mils, and they can be sealed, sometimes with or without an overwrap bag. And then of course, something on them to show that it's tamper evidence. So if someone has touched that cell therapy during transport or some other stage, you can tell that's happening. That's really important to make sure that the patient's getting exactly what you expect the patient to be getting. Quality control samples are often required, and I'll talk about that more in the next part of my presentation. And then finally, the chain of custody must be maintained throughout. So it's not good enough just having a therapy that you know is going to work and you know it's proper. You've got to be able to prove that this sample was taken from patient X on a particular date. It was cooled. Here's the cooling run. It was then stored. It was then thawed by this person. This is the exact process that underwent. And the reason to have that whole chain of custody is because when you are treating patients, particularly sick patients, you can end up sometimes they have an adverse reaction to the treatment, or they can have an adverse reaction to something else at the same time as the treatment. Investigations will have to be carried out to find out what the problem was. So you've got to be able to prove that the treatment that you've given them was done properly as per the approved process. But moving on to the quality control segments, which is quite common, and they're mentioned briefly earlier on actually in one of the sessions earlier today. So what are quality control segments? So I've got here an image on the right hand side, which is a cord blood bag, where quality control is used quite a lot. You can see the main bulk of the bag, that's the bulk of the cord blood, which is the treatment in this case. But also you can see sort of around the top of the bag, there are some of the tubing, they're sealed small bits of sample at the same time. And the idea is this can be thawed independently to get an assessment of the bag. So often this will be done if there has been an adverse reaction. You can thaw this quality control segment and see, okay, this was the exact sample that was given to the patient. prepared at the exact same time, frozen the same time, same cells, same cryoprotectant. Was something wrong with these cells? It can be used sometimes if there's been some sort of deviation in the cooling process to check if the cells are good or bad, or in terms of matching if you want to get a small bit of the sample to match with them. Of course, typically these are very small volumes, about 0.5 ml or so, because every milliliter you put into quality control is 1 milliliter of cells that you aren't giving to the patient, which is really how the treatment works. They're typically quite small. However, there's been quite a lot of literature over the years, and I've just got sort of headlines of some papers on this, that have found that the quality control segments tend to deviate sometimes from the bulk sample that's being cryopreserved. And of course, that's a problem, because if the point of your quality control segment is meant to be identical to what I've given the patient and they're somehow different, that can be a problem. But we can look into this from a cryobiological point of view and work out what the problem might be in that case. So I have here, I'm going to show you a video of what happens during cooling. So, and I apologize, this is in degrees Fahrenheit because that's what our thermal camera uses. But essentially, this is a thermal imaging of a cryo bag with these control segments during cooling. So we have the main bag here, and then the quality control segments are here. And what you'll see as we start cooling, at some point ice will form through the sample, and that will be obvious through a jump of temperature because ice formation is an exothermic event. If I just press play, we can see the bag beginning to cool. It gets to 32, which is 0 Celsius, and then about 26 Fahrenheit, about -4 degrees. Just there, you can see a jump in temperature of the bag when ice starts forming throughout the bag as part of the cryopreservation process. However, if you look at on the left-hand side, the quality control segments, they've still not nucleated. In fact, they only nucleate at that point there, which was about -17 Fahrenheit to -27 degrees. And that's really a key difference when it comes to cooling. So you've got the main bag itself, ice forming at -4 degrees, ice forming in the quality control segments. In this case, it's 0.5 ml, but it is volume dependent, about -27 degrees. So I'll just jump on to the next slide. And then we can see a difference when we end up thawing the sample. So this is cord blood again. We did a study looking at these quality control segments. We cooled down the bag in the quality control and then thawed the quality control in the bag separately and looked at the post-thaw outcomes. So we looked at total nucleated cell recovery, the viable mononuclear cells, and the viable CD45 positive cells. And you see they were all, the recovery was worse in the quality control segment compared to the malt bag. The p-values are put above the graphs. However, that's not true in all cases. So the viable CD34, the annexin 5 viable, which is an indicator of early stage apoptosis, and the colony forming units, there wasn't a key difference. So it shows in some cases the lower nucleation temperature damaging in some measures, but not in other measures, and for some cell types, but not some other cell types. So why is this a problem? And I won't go into this in too much detail in the interest of time, and also in the first part of this this session a couple of weeks ago, Charlie Hunt gave quite a good talk about ice nucleation problems in PBMCs and blood-based therapies. But generally, very briefly, what you see happening here, if you imagine this image of the long tube is a vial or a quality control segment at a small volume, when ice forms in a sample, only pure water is locked away as ice. So all the cryoprotectants, the cells, all the other sugars are concentrated because water is being removed from the system, which gives osmotic shock to the cells. At a high temperature, if ice forms, say at -4 degrees, the amount of ice that forms initially is fairly low, so the osmotic stress is lower. But if you have a system where ice forms at, say, -27 degrees or -20 degrees, a lot more ice forms initially very rapidly, which gives the cells a larger osmotic shock. So cells that are sensitive to osmotic pressures and osmotic changes will tend to be damaged by this process. The second cause of damage that can be caused by nucleation is due to rapid cooling rates post-thaw. So post-nucleation, sorry. So you have your cells, they nucleate, the temperature then rises because it's an exothermic event, but then you end up with quite a big temperature difference between the temperature of the sample and the temperature of your control rate freezer. So after that nucleation event, you tend to get cooling that's too rapid, which can then damage your sample more. If you've got a large bag, say a bulk sample, say 20, 30 mils, that sort of insulates itself, so it's cooling not as rapidly, but a very small segment will cool very rapidly, and that can then be damaging because you've got cooling that's too rapid. And then finally, if you cool very rapidly, you won't get proper ice formation and cooling, it won't be fully formed, So you can get I3 crystallization and thawing, and I think the next talk in the session is going to go into that in more detail, so I won't talk any more about ice recrystallization. So how do you actually then interpret the quality control segments, particularly if you're scaling up from some research environment to something that you want to use in the clinic? So the first thing to say is ice nucleation is a random event, but it is volume dependent. So this graph on the right-hand side is some work we published last year. And if you look at the first area on it, that's a 70 ml cryo bag, and you can see it nucleates between 0 degrees and -10 degrees. As you get smaller, it tends to get much lower. So for a 1 ml cryo vial, it can be as low as -20. A 0.25 ml cryo straw gets even lower in temperature. But one of the advantages of that is often what we find is when something's going from a research environment to the clinic, often the volume increases because you need larger samples in general for patients. So that's a good in general because it means that nucleation will be less of a problem, because if your cells are sensitive to nucleation, then having a larger volume is a way around it. You need to carry out, however, some sort of studies early on to determine how sensitive your cells are to nucleation, and if they are, quality control segments might not be the way to go if you want to assess viability. If you're doing something like assessing matching, it doesn't really matter, but if it's something like that, doing a quality control segment won't be sufficient if your cells are sensitive to nucleation. And then the last thing to be aware of is if you're cryopreserving cells that are composed of multiple different cells, different cell types are sensitive to nucleation in different ways. So say, for example, in the graph I showed previously, the CD34 cells weren't very sensitive to nucleation, but the CD45 cells were very sensitive to nucleation, which means if you have a big problem with nucleation at low temperatures, you'll tend to find that the ratio of those two cell types will vary post-on. That's something that you need to consider very early on if you are going to use quality control segments as part of your treatments. So just going on to the last bit is a sort of high-level overview of the other practical considerations that you need to consider early on when you're moving from sort of more lab-based research to a clinical application, and things that are good to try and get right early on because it'll save you a lot of time later on. The first thing to check is do early explorative tests. So for example, a lot of work we come across from research environments is using calf serum, FCS. Animal-based products in general are quite difficult to get approval for and to use. You've got to go through a lot more hoops for that in most cases. But often you actually need calf serum to help your cells improve. They're just often in culture medium. And if you know that your cells don't need serum or calf serum in order for cryopreservation, normally I'd recommend don't use it even in the very early research stage, because that means if you do want to end up putting something into the clinical environment, you'll find that you've already got a huge amount of data where you're not using calf serum as opposed to having to change it later stage in the day. Another thing that's quite important to consider very early on, because the earlier you consider it, the less work it'll be overall, is how the cell system responds to different cryoprotectants. So when you end up using something that will be used into a patient, you typically have to have a GMP process, which includes GMP cryoprotectants. There's a lot of GMP cryoprotectants available, and it's usually a good idea early on just to test a few of them and find out one that you know is going to work, and then either stick with that one, or if it's too expensive to use, at least be aware that you have a cryoprotectant you know that you're going to use ultimately, because what you don't want is to do years of work, then move to a clinic, find you've got to find a new GMP supplier of your chemicals, and then you can't get the one that's actually going to work optimally for your treatments. The penultimate one is be very careful about when you decide to use your therapy. So most cell therapies are thawed at the bedside of the patient and transfused straight away. However, one thing we often see is in research environments, often you'll thaw your cells, you'll then have a recovery period for say 24 hours, 48 hours before using it. However, from a practical perspective, when you're using something with a patient, that's very difficult. If you need to do a post-thaw culture, typically you'll have to thaw your sample, then move to another GMP environment, culture it for a few days, and then transfer it to the patient. And that just makes the process much more complicated, but also makes it much more expensive. And the more expensive your treatment is at the end of the day, the less widespread it's going to be used. And then finally, it's always best to try and make the process simple enough. We've found many cases where we're using this in hospitals, and often it's the nurse or the doctor who's having to thaw this sample, infuse the patient. They've got another 20 jobs to do, and they're not cryobiologists. So we found that simplest and most straightforward you can make your process at the end of the day actually really help when it comes to using anything as a cell therapy at the end of the day. So just to summarise what I've been saying before I open up to the questions is, remember, most treatments that we use originate from clinical research, but when you move to the clinic, cryobiologically the cells still respond to the same, but you have a lot more restraints and typically a lot more complex systems that you've got to pay attention to and rules you've got to follow. Quality control is a key issue, but make sure that if you're using quality control segments, you're very aware of volume changes and you take account of is nucleation and how that will affect your cell type if you have a cell type sensitive to nucleation. And then early on, the earlier as possible, you can try and design in features that will make your life easier when you end up going to try and get regulatory approval, the better, because the sooner you do it, the easier it is to change a process that's fairly new than it is to one that's fairly old, and also means the most data you'll have at the end of the day when you actually go to try and get approval for any of your treatments. So thank you for your attention, and I think I can open for questions.
Okay, well, thanks very much, Peter. That was a great presentation, very concise and clear, and some interesting images there. It's always good to see what's actually going on in cryopreserved systems rather than making assumptions. So maybe if you could stop sharing your screen, please, Peter, and then I'm just looking down the questions. I can't see any immediate questions at the moment. What I might do is very quickly ask you one that I have. I have a few questions, but I'll just ask the one that comes to mind the most immediately and is maybe most relevant to everyone. And that's when you're often dealing with people who are just developing or adapting new systems, what's the biggest challenge you find people have, or surprise that they have when they're moving from lab protocol or lab equipment to an actual therapeutic manufacturing situation?
So I think the biggest challenge we typically have is the one I mentioned very briefly in my talk, is generally you've got to make sure that at the end of the day, when you've thawed your sample, that can then be placed immediately into a patient. And there's sort of two challenges where that comes from. So one challenge is people often need a recovery step for their cells, which is one thing I mentioned, but you can kind of get around. And the other thing is, when you're doing stuff in the research environment, you've got to make sure that even though you're going to use it immediately, do test 24 hours, 48 hours, 72 hours post-thaw, because one thing we find is people typically sometimes, especially ones who don't have a background in cryobiology, but they are using cryobiology processes, is they'll thaw their samples, they'll then take a viability measurement directly on thaw, and if it's good, they'll say, okay, end of story, that's good. But of course, when you inject it to the patient, that treatment's supposed to have an effect over several days or up to a week. And often what we'll find is you get apoptosis occurring immediately after thaw. So your results on thaw might be 70, 80%, but actually after a day or two, it can drop as low as 30, 40%. And therefore the treatment won't work, because when you inject it into the patient, the cells are going to die inside the body. So I think the biggest challenge is you really got to make sure that when your treatment is thawed, it's good enough to go into a patient, but also maintains being good enough. You're not having apoptosis happening when it's meant to be doing some sort of therapeutic function inside the body.
Okay, and there was one other question, apart from people saying what a cool video you've got at the start. What are the GMP cryoprotectants that you mentioned? I know this has been a problem for people to sort out and to find out whether there are in fact any GMP cryoprotectants.
Yes, so there's a few out there. There's a lot more in development. I think that CryoStore is GMP compliant, or at least done to a GMP level. And I think that's certainly the market leader at the moment. There's a few other ones, a few other DMSO-free ones coming online as well. But it is true that there's not that many available. And one thing people often do sometimes is they'll just buy GMP grade DMSO on its own as well, and then do something internally in the lab with GMP components.
Okay, thanks. I think that's an important point, because DMSO is made as a therapeutic, so it can be made to GMP, whereas the other cryoprotectants are excipients and would not normally be made, wouldn't get a GMP license. They have to have other arrangements. Yeah. Okay, that's great. Thanks very much, Peter. So we'll thanks a lot. We'll switch to Robert Ben now, who's hopefully is ready to give his talk. Welcome, Robert. Would you like to introduce yourself?
Yeah, no problem. Of course.
I mean, I can do the usual a spiel, or you can say what you prefer to have heard about you.
No problem. So my name is Robert Ben. I'm a professor at the University of Ottawa. My research expertise is in the area of drug design, medicinal chemistry, and of course cryobiology. And what I'm really going to talk to you about today will be a high-level talk. I just want to make sure I can share my screen. Okay, you should be able to see that, I hope. Yes?
Yeah, that's great.
Okay, fantastic. So what I'll do is I'll give you sort of a high-level talk, which is really going to discuss a new cryopreservation technology, which we refer to as isocrystallization inhibitors, or as we abbreviate as IRIs, and talk to you about how this technology is actually changing how we think about cryopreservation. So I think in order to set the stage for this properly, it's worth going back to the sort of the very beginning and looking at that formal definition of what really cryopreservation is, even though a lot of us do this on a daily basis. And as you're aware, it really entails storing a sample, whether that be cells or tissues, whatever, at a very cold sub-zero temperature, say typically -200. And the significance of this is that at these temperatures, of course, all biological activity and biochemical reactions have effectively ceased. But I think it's also important to mention that, as we're aware, that when cryoprotectant solutions are not used, the cells or tissues that we're cryopreserving are often damaged due to the freezing during the approach to low temperatures, or on the other side, the warming to room temperature. And I think it's this statement which causes a little bit of confusion sometimes, because it implies that if we use a cryoprotectant, that in all cases, usually, there is no issue and we get really good results in terms of post-thaw viabilities, recovery, functional capacity. And that's led to statements such as the whole idea that preservation of cells and therapies is a solved problem. Immersion of cells in 10% DMSO and cooling to cooling rates with 1 degree Celsius per minute is sufficient. And unfortunately, as we've seen from the first part of this workshop and also even today, that nothing could be further from the truth. In fact, Peter Mazer, as well as many other researchers back in the mid to late 60s, have published a lot of data to show us that, in fact, each cell type has its own optimal and unique cooling rate. And if we're using a cooling rate which is on the slow side of that optimal rate, we observe more cell death. Similarly, if we're using cooling rates that are higher than the optimal cooling rate, we see extensive cell death. And the reason for this really has to do with what's happening during the cooling. So when we take a sample and we start to cool this below 0 degrees Celsius, at some point we get a nucleation event which occurs. It's a random event. It usually occurs extracellularly in most cases. And with an optimal cooling rate, we mitigate the cellular injury. We don't eliminate, but we mitigate it. However, when we're on the slow side of that cooling rate, we can get extensive dehydration, which causes a lot of issues with the cells, ultimately solute toxicities resulting in cell death. While on the other side of that curve, the faster cooling rates, we fail to get dehydration, and as a result, we get intracellular ice formation, which is generally regarded as being lethal. Of course, we know that we use cryoprotectants, and these help to mitigate some of the cryo injury associated with freezing and thawing. And as we saw in the first part of the workshop, there's essentially really two large classes of cryoprotectants: cell-permeating cryoprotectants and non-permeating cryoprotectants. As the name implies, those that are permeating are able to cross cell membranes, and they do a lot in terms of the mechanistic side. Typical cryoprotection agents for this, or CPAs, are things like glycerol that we are very familiar with, as well as DMSO, or dimethyl sulfoxide. But despite all of this knowledge and practice, really the current state of the art looks much like what I'm showing here. So here we're looking at essentially 4 different cell types. using a number of different cryopreservation media, some specifically engineered for cryopreservation, with varying concentrations of a cryoprotective agent, something like dimethyl sulfoxide. And as you can see, as I've been talking, we really have a long way to go in terms of doing better, because post-thaw recoveries are really not what they should be. And this is really unfortunate, especially with the last 8 years or so, maybe even decade now, where we've seen tremendous advances in the areas of organ engineering, regenerative medicine, cell therapies, even printing three-dimensional tissue constructs for various applications. All of these potentially life-changing, life-saving therapies, we really haven't seen much of a translation into the clinical markets or areas, as well as a full market deployment. And really, this comes down to essentially one main reason, and that is that we really don't have a shelf life for these products. Ultimately, what this means too is that we really need to improve the cryopreservation strategies, because that's the bottleneck. As we've seen previously, again, I think it was in the first part of the workshop, we are acutely aware of the fact that a lot of cryoprotective agents, such as dimethyl sulfoxide, have been fully documented as being cytotoxic, which causes problems. But in addition to that, there have been an increasing number of reports talking about the functional capacity of various stem cell progenitors, and how that can be altered or can be compromised even during the cryopreservation process. And when we're dealing with something like a progenitor cell, this can potentially be an issue, because we don't want to compromise that ability to self-renew or to differentiate. Now, with all of that background, cryopreservation and what's happening actually when we're cooling a cell or a tissue is incredibly complicated. And while there are many mechanisms by which cryo-injury can and does occur, it's important to note that the most significant cause of decreased viability and impaired function during cryopreservation is that physical or chemical damage resulting from ice crystal formation, and in particular, the uncontrolled growth of ice in the sample. And it's worth noting, as we'll see again in a few minutes, that conventional cryopreservation strategy, as well as cryoprotective agents, really don't do much in terms of mitigating this mechanism of cellular damage. So in my laboratory, when we talk about uncontrolled growth of ice, we're really focusing on this process of ice recrystallization, or this phenomenon known as ice recrystallization. And formally, it's defined as large crystals growing larger at the expense of small ones. The implication of this is that when we freeze a sample, take it down to -80, -100, -200, whatever that set point temperature will be for storage, we end up with very small ice crystals. But as a function of time and increasing temperature, of course, we get this thermodynamically allowed process where we have this grain coarsening. So these small crystals grow larger. And it's these large ice crystals which actually become extremely damaging to the cells or tissues that we're cryopreserving. So in an ideal world, the best approach to do this is to really control that ice crystal growth, such that after we freeze and we store the compound, we store the sample, and we warm it, we keep ice crystals small so as to mitigate the cellular damage that occurs with that grain coarsening effect. And the really short story of all this is that we're able to do this, and we're able to do this actually quite well. Over the last decade or so, our laboratory has been working on rationally designing small molecule ice recrystallization inhibitors. I've shown you some general structures here of essentially 5 different classes. We have 8 now. And while the physical chemical properties of any of these molecules may differ, they have one key attribute, and that is that they're all very effective at controlling ice recrystallization in a frozen sample. And to illustrate that point, the image here on the top left is an image of a frozen wafer actually containing 6% dimethyl sulfoxide, or DMSO. And you can see that the crystals here are quite large. But in contrast, when we repeat that experiment and freeze that wafer in the presence of an ice recrystallization inhibitor, we end up with crystals that are incredibly small, and they maintain that small size, and thus ultimately control the cellular damage that we see. So this is truly a platform technology which over the years we've been working on and exploiting it in a number of different model systems, such as human red blood cells, cardiomyocytes, various progenitor cells, even tissues. And the advantages of the technology are essentially, first and foremost, that we control extra and intracellular ice growth, ultimately mitigating that cellular damage that's happening as a result of freezing. In many cases, we're able to use very slow warming and don't have to use very fast cooling rates. And in addition to that, we can use oftentimes higher sub-zero storage temperatures for biological materials. The compounds protect against transient warming injury and also have reduced toxicity. And that's kind of a twofold statement, because in many instances, we can often remove or dramatically decrease the amount of cryoprotective agent, which is sometimes accompanying the isocrystallization inhibitors, things like DMSO or glycerol. So in the next couple minutes, I'm just going to illustrate a few of these points and focus particularly on controlling extra and intercellular ice growth, and focusing on transient warming, and then protecting the post-thaw functional capacity of different types of progenitors. So first and foremost, what we're looking at here using a red blood cell model, and this has been done in collaboration with Dr. Jason Acker's lab. He and I have been collaborating together for probably almost a decade now. What we've done is we've taken a 15% glycerol solution with red blood cells and essentially frozen it. And this is what you typically see in terms of ice crystal morphology, or habit, if you will. And when we add the isocrystallization inhibitor, so I'm showing you a structure of what we call the para-bromophenyl gluc and what we call 4-CLA, which are two very effective isocrystallization inhibitors, immediately you notice that the crystal sizes look extremely different, and of course are much smaller in the case of using an isocrystallization inhibitor. In Dr. Acker's talk, we learned a fair bit about transient warming events and transient warming injury. And as I mentioned a few moments ago, the IRIs are very effective at controlling that. If you recall, a transient warming effect is really not thawing of the sample, but just inconsistent fluctuations in temperature. The problem with this is that when we have these warmings and then drop in lower temperatures, what we see is an acceleration in isocrystallization. So we start to get this grain coarsening effect, which, as you recall now, is detrimental to cell post-thaw viability of cells. So we designed an experiment where we did successive transient warming events, freezing and thawing, going from essentially -80 to -20 and back. And what you'll notice here in the top panel, images A1 to A4, we're looking at essentially a 15% glycerol solution with red blood cells. And as we go through these transient warming events, you'll notice we see grain coarsening, which is a function of that. And again, I want to point out that these samples have not been thawed, actually. They're just changing temperature, warming, and going back to -80. In contrast, though, when we use the isocrystallization inhibitor, in this case is para-bromophenyl gluc derivative, you'll notice that the crystal size remain constant even after multiple transient warming events. And of course, the real proof of this now is to then take these samples and then look at the number of red blood cells that survive these transient warming events. And that's what we've done here, looking at 1, 2, and 3 different cycles of transient warming. And the green bars are the 15% glycerol controls. And as you'll see, and you'll notice these bars decrease, and we're getting more and more hemolysis as a function of the number of cycles we're doing because of transient warming injury and isocrystallization. But in contrast, when we take that 15% glycerol solution and supplement it with an isocrystallization inhibitor, you'll see that we essentially maintain the number of intact red blood cells. And that these orange or yellow bars are comparable to the clinical standard for cryopreservation of red blood cells, which is using a 40% glycerol solution. We've also been able to do a fair bit of work looking at using the isocrystallization inhibitors to control intracellular isocrystallization. And this is actually really exciting because we have classes of ice crystallization inhibitors that are able to, as the name implies now, permeate through an external cell membrane and control the ice growth inside the cell. So what we're looking at here actually is a stained image of human umbilical vein endothelial cells. And when we zoom in, we're looking at actually a nucleus. And actually this is held at -20 degrees Celsius. And you'll notice you see this cobblestone effect. And all these dark images are actually large ice crystals within the nucleus of the cell. In contrast, when we use the ice crystallization inhibitor, though, you'll notice at the same temperature under the same conditions, the crystals remain small, actually, and ultimately result in increased post-thaw viability and recovery. So at this point, I'd like to just switch and talk a little bit sort of about stem cells, in particular induced pluripotent stem cells. And this work has been done in collaboration with our colleagues at the National Research Council and the Human Health Therapeutics Group, who have a large interest in iPSCs. And of course, iPSCs really don't need much of an introduction. They're a very important cell type in terms of modern cell therapies used for all different types of applications. And they're a very rich source of many therapeutically relevant cells. One of the biggest problems, though, is often in recovering these cells after cryopreservation. Typically, viabilities are quite low. And of course, functional capacity can be compromised, which we'll get to in a few moments. So what we did was we deployed the ice crystallization inhibitor technology actually to increase post-thaw recoveries of the iPSCs. The control that we use in this case was a commercially available M-freezer solution, which had been supplemented with a 10% DMSO solution. And I know there's a lot of bars here. Essentially, we've looked at probably close to 10 different ice crystallization inhibitors. I'm just showing you the structures of 4 of them, which are of the same class, what we call aryl aldonomides. That name is not really ultra important right now, but I want to focus on the one in the top right corner here, which we refer to as 2FA. And if you'll notice that at doses of 5 and 10 millimolar in the supplemented M-freezer solution, we're almost doubling the post-thaw recoveries of these iPSCs. And of course, this work has been optimized, but I'm just showing you initially the preliminary data. But we're interested more actually in the functional side or functional state of these iPSCs. So in this instance, one of the first things we looked at was the ability to proliferate immediately after post-thaw. And we've used the IncuSite technique to look at confluence and measure confluence as a function of this real time. And initially, I would like you to focus on the blue line here, and of course the red line. So the blue line is the M-freezer solution, cryopreservation solution, supplemented with 10% DMSO. That's our baseline. If we take that M-freezer solution and we supplement it with Rho kinase or ROCK inhibitor, as we heard earlier, which is important for stabilizing these types of pluripotent stem cells, we see the expected increase in proliferation. But when we add the IRI to that same solution, we see significant increase now. In fact, these cells are much healthier. They're dividing much quicker and overall in a much better state immediately coming out of cryopreservation. The green line here is interesting for another reason, and that is that because this is using the M-freezer solution supplemented with the isocrystallization inhibitor, but we've removed the ROCK inhibitor at this point. And you'll notice that this green line is very similar to the red one, which includes the ROCK inhibitor, the Rho kinase, implying that we could probably remove ROCK inhibitors actually for the preservation of these iPSCs, as long as we use an isocrystallization inhibitor. We've also done a fair number of studies looking at whether iPSCs that have been treated or cryopreserved with the ice crystallization inhibitors retain various pluripotency markers, such as OCT4, SOX2. And this has been done in collaboration with doing multiple freeze, thaw, and culturing cycles where the cells have been frozen for up to 2 weeks, cultured then for another week, and then thawed. Then frozen again and continued. And as the data suggest here, iPSCs that have been treated with 2FA have retained their pluripotency. However, as we learned in the first part of the workshop, one of the gold standards actually for this type of work with iPSCs is really the teratoma xenograft model in immunocompromised mice. And when we do this study, what we really look for is evidence of all three germ layers, ectoderm, endoderm, and mesoderm. And what you're looking at here, images from IPS that have been frozen using the typical M freezer conditions that we've used with the 1 degree Celsius per minute freezing rate and 10% DMSO. When we do the same experiment using the ice crystallization inhibitor, again, we see evidence of the ectoderm, mesoderm, and endoderm again. So implying that the differentiation capacity has not been compromised upon exposure to the ice crystallization inhibitor. And in the last minute or so here, I'd like to continue on this idea and show you how we've actually pushed this technology even a bit further. So in the last 6 months or so, we've been focusing a lot on looking at human neurons that have been induced actually from iPS cells. And of course, this is a very timely approach because these types of neurons have been used in many disease modeling, drug discovery, and toxicity screenings, as well as clinical treatments. The differentiation process is a fairly lengthy one, starting from the iPS, but essentially what we did was we pushed these to neuroprogenitor states and then differentiated them into neurons. And from there, on day 63, we froze them using CryoStor 10 as a control, and then a CryoStor solution supplemented with the ice crystallization inhibitor. And we plated them and froze them on MEAs, multi-electrode arrays. And initially, when we thaw them, we see statistically significant increase in post-thaw viability, but that wasn't the most interesting thing that we saw. What we did was we took these neurons, plated out on the MEAs, and we followed them and watched them mature and start to function and start to fire as a healthy neuron should. And what you'll notice in these raster tracings is we're looking at day 20, 27, and 42. So this is days in vitro when these have been cultured. And you'll notice that we see a lot of asynchronous firing in the case of neurons that have been cryopreserved with the CS10. However, in contrast, when we use the ice crystallization inhibitor, you'll notice that at day 20, everything is starting to line up nicely. These neurons are firing more often, and they're starting to be very synchronous. We've gone out actually, and you look at right here, this is day 132 in vitro. You can see that there's still a significant difference with the CryoStor control versus the isocrystallization inhibitor. And just by background information, we've actually pushed this out now to over 210 days with neurons that have been treated and cryopreserved with the ice crystallization inhibitors, whereas the CryoStor 10 control neurons tend to die off at about 160 days. So at that point, I just like to leave you with a couple of high-level conclusions, and hopefully I've been able to convince you that the most significant cause of decreased viability and impaired function in cryopreservation is usually due to the uncontrolled growth of ice in the sample. Conventional cryopreservation media containing DMSO, glycerol, et cetera, do nothing to control this actually. And that the small molecule isocrystallization inhibitor technology can not only control extra and intracellular ice growth, but can also result in increased post-thaw viability and or increased cellular function. And with that, I'd like to acknowledge all these sources of funding and my very talented graduate student team who actually do all of the work. And I'm happy to answer any questions if there be any questions at this point.
Okay, that's great. Thanks very much, Robert. There are a few questions, in fact, but maybe I could just, if you don't mind, just ask one, and then we can come back to them when we have get to the Q&A session. Is that okay, Jason? Okay, so the question I noticed was, do the ice recrystallization inhibitors have to be used with glycerol, or could you potentially use them without?
Oh yeah, good question. I didn't elaborate too much on that just because of time constraints, but depending upon the type of cells that we're cryopreserving, and how they behave. We have a number of instances where we can actually remove cryoprotectants such as glycerol or DMSO. But more often than not, we can dramatically reduce that concentration. But again, it's highly variable depending upon the type of cells that we're essentially cryopreserving.
Okay, great. Well, that's a great talk. Thanks very much, Robert.